Muhammadiyah Makassar, 2013 Medical Doctor Profession, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Makassar, dan 2020 Master of Biomedical Sciences, Postgraduate School of Hasanuddin University. Untuk work dan organization experience, di sini ada Indonesian Medical Association, Makassar City, lecturer at Muhammadiyah Association, third secretary of the Indonesian Physiology Association, South Sulawesi branch, and secretary of the Physiology Department, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Makassar, and Quality Assurance Unit of Bachelor of Medicine Study Program, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Makassar. Kepada Dr. Fatimah Mapanyompa, kami persilahkan.
Check. Okay. All right. Thank you to our Master of Ceremony. Alhamdulillah, wassalatu wassalamu ala Rasulillah, wa Nabiyya Muhammad sallallahu alaihi wasallam, wa ala alihi wa ashabihi ajmain. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadan abduhu wa rasuluh la nabiyya ba'da. The Honorable Dean of Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Makassar, Profesor Dr. Suryani As'ad, Magister of Science and Clinical Nutrition Consultant, the Honorable Vice Dean, and then our national and international speakers, the committees, and all participants of Unismuh Medical Conference 2025. Assalamualaikum warahmatullahi wabarakatuh. I am Dr. Fatima, and this afternoon I will assist as a moderator for upcoming session of plenary lecture. And first of all, I would like to greet our outstanding speakers. So the first speakers will be delivered by Professor Dr. Apoteker Zulis Ikawati from Gajah Mada University. And then our second speaker is Professor Dr. Ashfaq Ahmad from University of Lahore, Pakistan, which at the moment will be joining us via online in Zoom meeting. And then our third speaker is Professor Dr. Suryani As'ad, Magister of Science and Clinical Nutrition Consultant from Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Makassar. And our last but not least speaker is Professor Timothy J. Q. MD, PhD from Taipei Medical University, which will also joining us online as well. So, before we begin, I would like to invite our first speaker, for Professor Dr. Apoteker Zulis Ikawati in front of the podium. Would you please? Okay. Yeah, to the committee, would you present the curriculum? Okay, we have seen the curriculum. So, can you zoom in the files because I cannot read clearly, yeah, because it is a very small, yeah. I cannot read clearly. Can you zoom in to the committee? Yeah. So, thank you, Prof, for having us here. So, first of all, I would like to read your curriculum vitae, yeah. So, Professor Dr. Zulis Ikawati, apoteker, yeah, born in Purwokerto, and for the academical degree, yeah, Bachelor of Pharmacy in Universitas Gajah Mada, as well as for the Okay, thank you so much. Yeah, thank you. Okay, right now I can see clearly. Yeah. Maybe you can scroll down. Yes. Right. Okay. So for the academical degree, yeah, for the Bachelor of Pharmacy, yeah, in Universitas Gadjah Mada, and also for the pharmacist profession, as well as in Universitas Gadjah Mada, and Doctor of Philosophy in Pharmacology in Ehime University School of Medicine in Japan. And for the work history, yeah, or experiences. Right now, professor is as a head study program of doctoral in Ilmu Farmasi, Fakultas Farmasi, Universitas Gadjah Mada. And we can see right here, there are so many experiences of our speaker in organization and also many activities, yeah, as you can see on the screen. Yeah. Okay, so without further ado, I would like to invite our first speaker, yeah, Professor Dr. Apoteker Zulistikawati, to have your time. Please, time is yours.
Okay, thank you for the introduction. Good afternoon, distinguished guests and also colleges and participants. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thanks to Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Makassar, and also the committee for inviting me as one of the speakers in this very prestigious event today, Umedhicon 2025, and it is very great pleasure to be here. And in this occasion, I would like to share insight about the role of pharmacogenomics to optimize drug therapy. I'm Zulistikawati from Faculty of Pharmacy, Universitas Gadjah Mada. Slide, please. Yep. In this presentation, I will cover about 4 topics. We start with the history and understanding of pharmacogenomic, and then continued by pharmacogenomic in pharmacodynamic phase, and continued with the pharmacokinetic phase, and I will provide examples of pharmacogenomic labeling that direct us to implementation of genetic profile in clinical setting. Okay, slide. Well, we start with the history of pharmacogenomics. The recognition that the genetic variant can influence the individual response to medicine first proposed by the English physiologist Carrot. And he suggested that enzymatic defect can lead not only the accumulation of endogenous substrates in inborn errors of metabolism, but also to accumulation of exogenously administered substrates like drugs, foodstuffs, toxin with clinical consequences. And there are several examples that already documented, include hemolysis due to primaquine in the soldiers with G6PD deficiency, then neuropathy from isoniazid in slow acetylators individuals, and also prolonged apnea from succinylmetonium in the people with plasma cholinesterase abnormality, and also life-threatening hypertension from dibrisoquine in people with CYP2D6 deficiency. These examples then become a foundation and for the development of pharmacogenomic. Slide. Slide more. Yes. It is also supported by the fact that, please show the all in the slide. Just click, click, click. Yes. Okay, thank you. Yeah. This is supported by the fact that people don't respond uniformly or in the same way to the medicine. Adverse event may occur in some people, but not in others. Doses can be different each other, and efficacy can vary. We see in the slide that in the table that no 100% rate of response. Yeah, so many drugs like several drug class have only about 25 to 60%, etc. So there is no perfect medicine. That's in this explained that there is something that influence the individual response to medicine. Variable response to medicine are known to occur in some population and also the adverse event. Okay, slide please. Yep, slide. So there are multiple factors that influence the medicine response, yeah, of the individuals. When a patient comes to the doctor and then the doctor gives the diagnosis, the proper diagnosis, and then give the prescription with the dose regimen with a properly prescribed, and patient have complied to the medication and also control the interaction with concomitant drugs, but still there is a factor that can influence the drug response, namely, yes, slide. Yes, last but not least is genetic difference among patients. Still, genetic should be considered, and this is the foundation of the pharmacogenomic. Slide. Yeah. So from that foundation that emerged the field of pharmacogenetic or pharmacogenomic, which is defined as the intersection between pharmacology and genetic, which studies how an individual's inherited variation in gene affect the body's response to medication and may be used to predict future response to therapy. Okay, slide. Yeah, we can see the illustration. There is a couple, a group of patients with same diagnosis, with same prescription, but then they can respond differently. At least there are 4 types of response to the medicine. The first is the first group, number 1. This is the most fortunate group because the drug is not toxic and beneficial. But the second group, number 2, this is the most unfortunate group because the drug become toxic and not beneficial. Other group might, like in 3 or 4 group, number 3 or group 3, drug toxic but still beneficial. While in the 4th group, the drug has no response at all, drug not toxic and also either not beneficial. So with the same diagnosis, with same prescription, still people can respond differently to the medicine. And then from this emerged the field of precision medicine. This is the emerging practice of medicine that use an individual genetic profile to guide decision made in regard to the prevention, diagnosis, and treatment of disease. Slide. Yep. And the goal of precision medicine is to maximize the drug efficacy, minimize the drug toxicity, predict patients who will respond to intervention, and aid new drug development. Slide. Yep. And it is should understand that there is a foundation of pharmacogenetic or pharmacogenomic, namely differences in genetic code between people. There are 2 terminologies that usually used in this field, mutation and polymorphism. I think this is also common knowledge for you, I think, but this is to refresh our knowledge. Mutation is defined as a difference in DNA code that occurs in less than 1% of population. It is often associated with rare disease like cystic fibrosis, sickle cell anemia, Huntington disease, while for polymorphism, it is defined as difference in the DNA code that occurs in more than 1% population, and this is less likely to be the main cause of disease and may have no visible clinical impact, but it still can cause the inter-individual variability in drug response. Okay, slide. Here the illustration of how the single nucleotide polymorphism happen, like this. Yeah, this is a one region of gene. we have two subjects, subject 1 and subject 2. The subject 1, in this gene, the sequence of nucleotide base is A and T, AT, and it results in arginine as the amino acid. Yeah? While in the subject 2, in this location, in the same location, there is a change, base nucleotide become GNC. So then it will result a different amino acid, like glycine. So this is called SNP, where SNP result in alteration of the amino acid sequence in the corresponding protein, and like arginine substituted by glycine or for glycine. So it will give distinct protein structure, and in turn can result in phenotypic difference in between the subject, such as variation in response to medicine. Yeah, this is the commonly happen, the SNPs. Okay, slide. And this polymorphism can happen in different sites, like in drug target, like receptor, ion channel, or maybe enzyme, and also in drug transporter. And it can involve or contribute to the pharmacodynamic phase of the drug. While it can be also happen in drug metabolizing enzyme and also in drug transporter that contribute to the pharmacokinetics phase. So both pharmacodynamics and pharmacokinetics, pharmacodynamic, can influence the variability of the drug, either efficacy or toxicity. Okay, slide. Yep, we can see from this illustration that here the effect of genetic variation in pharmacodynamic and pharmacokinetic of medicine. See there, drugs, if an individual take a drug, then the drug will undergo the pharmacokinetic phase from absorption, distribution, metabolism, and excretion. Then they will distribute it into the site of action, and they will go to the pharmacodynamic phase. They will bind to the receptor and then insert or induce the mechanism of action, yeah, just depend on the drugs, and then give the drug response that finally give the pharmacological effect, either efficacy or toxicity. If there is a variation in genetic that happen on the gene encode for protein involved in pharmacokinetic process, so they will also change the pharmacokinetic profile of the drugs. The same is also true for the variation in pharmacodynamic phase. Yeah? So if there is variation in the receptor or the ion channels or enzyme that contribute to the pharmacodynamic phase, so then it can also change the response of individual to the drug. Yeah. Okay, slide. Yeah, today I think maybe in many countries, including Indonesia, when patients go to the doctor and get diagnosis, the clinician or doctor will prescribe until get the effective drug, yeah, effective response. We can see, yeah, trials and error. But next, when we use the genetic profile, next slide, please. Yep. Tomorrow or in the future, if we use the genetic testing and then consider the profile of genetic to make decision of the therapy, so it like a tailor-made because it is depend on the genetic profile of the patient. So hope to optimize the drug therapy. Okay, slide. Okay. Let's move to the example of pharmacogenomic in pharmacodynamic side. Yes, slide. I'll give you an example about the opioid receptor gene polymorphism. Sorry, this is gene polymorphism, should be aspirated, yeah? Okay, the opioid receptor, OPMR1, yeah, this is opioid mu receptor 1, gene polymorphism, it is occurs commonly and especially in the site of 118 position where the A allele, yeah, converted into G, yeah. So we call it A118G single nucleotide polymorphism. This variation can alter the receptor's binding affinity and also downstream signaling, leading to differences in how patients experience pain relief and also side effect from opioid. Clinically, this explains why some patients may require higher doses for adequate analgesia, while others are more prone to opioid-induced adverse effect. Yeah, because the difference in the receptor, yeah, that is influenced by the polymorphism. Here we saw a study, a human laboratory study gave 100 people with 0 milligram, 2 milligram, 4 milligram, 8 milligram hydromorphone, then measure the effect. And we see that when there is a different genotype profile, they will give different response to the opioid drug. Yeah, with AA is a wild type, and AG and GG SNP is a mutation or polymorphism. And to see whether in Indonesia we have such polymorphism, next slide, we did a study. We found that high frequency of the opioid receptor, OPMR1, A118G polymorphism in Indonesian population. Yeah, we found the G polymorphism is found around 90% of Indonesian population. This is just to contribute for the mapping, but I don't see further about the effect of this polymorphism to the response of the people against the opioid drugs. Okay, slide. Yep. Next is about the polymorphism happen in pharmacokinetic phase. We know that pharmacokinetic phase consists of absorption, distribution, metabolism, and excretion, but the most studied phase of pharmacokinetic is metabolism. We know that for metabolism of drug, the most enzyme contribute or work on the metabolism of drug is CYP, cytochrome P450 enzyme. And we know that there are several subtypes of CYP P450 enzyme, like CYP2D6, CYP A12, 1A2, 2C9, 2C19, etc. with this proportion. And from this sum isoform, the 2D6, 2C9, and 2C19 are the three largest isoforms that undergo polymorphism. Yeah, this many paper reported about this polymorphism, and it contributes to the various phenotypes. Okay, slide. Here, with the polymorphism of the CYP genes, can result in enzyme product with abolish, reduce, alter, or increase enzyme activity. So then it can result in 4 phenotypes of the population with poor metabolizer, meaning that lacking of functional enzyme, so the metabolism is very slow. Then the intermediate is the individual that have heterozygote for defect allele. Then the efficient metabolizer, this is the wild type. Yeah, this is the normal one, carrying the 2 functional gene copy, and the ultra rapid metabolizer. So the population can be divided into the 4 phenotypes depending on the genetic profile. And if some people have poor metabolizer, mean that the metabolism is very slow. We know that the general metabolism is, the purpose of metabolism is converting active compound or active drug into the inactive drug. Yeah, so if the metabolism happen, they will convert the active compound to inactive compound that will be eliminated later. So when the metabolism is poor, so it will give accumulation of drug, active drug in the body, yeah, increase the bioavailability. While for the ultra-rapid metabolizer will decrease the bioavailability of the drug. So we can see in the slide, there is a picture there. There is an imaginary line, yeah, this effective dose. If people have or ultra-rapid metabolizer, so the drug is rapidly metabolized into the inactive one, so sometimes cannot reach the effective minimum concentration. If they don't reach the effective minimum concentration, so they cannot give any response at all. So in that condition, the people with the phenotype need increased doses. Yeah? And in the contrary, if people have the poor metabolizer, so they lack of functional enzyme, so the metabolism is very slow, they will have accumulated an active drug. So if the active drug reach the minimum toxicity level, so then it can give toxic effect or toxic level. So that's why by understanding this phenotype, we need to adjust the doses to be prescribed to the patient. Okay, slide. Here the example, before or I think right now we still, because we don't use genetic profile or genetic testing for consideration, so if we have a patient, we just give any patient with 100 milligram, for example. But by using personalized medicine, we know the genotype and also the phenotype of the population, so then we can adjust the dose. For the ultra-rapid metabolizer, for example, they need higher doses. So we give 500 milligram, for example. But for the normal one, like extensive or intermediate metabolizer, we can give 100 milligram. But for the poor metabolizer, it will be excessive for them if we give 100. So then we can reduce the dose by like 10 milligram. Yeah. So this is the individualized therapy based on the personalized medicine. Okay, slide. Yep. Here I also try to map the genetic variation, and I do in Makassar, maybe 10 years ago. We studied the allele frequency distribution of gene 2C9 star 2 and 2C9 star 3 and also 2C19 star 17 in Buginese population. Why Buginese? I'm interested in Makassar population because you are in Makassar population reside in the near Wallace line. So we know that Indonesia is very wide, yeah, from the west to the east. So we have a different ethnics and also different phenotype. For the eastern Indonesian, we have a Papuan, yeah, etc. So this is very different in phenotype. While in Java, like me, we are like maybe Malay, they're similar with Philippines, I think maybe still similar. But Sulawesi or Makassar is interesting because we are lying in the Wallace, so between west and east. And we found that, slide please. Yeah, we find that some people have fast metabolizer phenotype, about around 16 in female and 2% in male fast metabolizer, but we didn't find slow metabolizer with the CYP2C9 and CYP2C19. Next. Then we want to see how about in Papuan. Yeah, Papua is interesting because different phenotype. So then I studied, and also the result is also interesting because we find the highest polymorphism in star 3 in the Papuan, but for the slow metabolism we cannot find in the Papuan. Yeah, just as the example why we need to map our genetic profile because Indonesia have variation. Okay, slide. Slide, please. Yeah, about to CYP2D6, we also tried with the Indonesian population, and we found that for star 10, we have almost similar with East Asian population, about around 34%. Yeah, because this polymorphism is very low in Caucasian. African American also less than 10%, but in Asia, like East Asian, we have about 40% of the CYP2D6 star 10 allele. Okay, slide. Okay, then this pharmacogenomic already transferred it, or slide please all. Yeah, translated into guideline and also FDA recommendation. Now FDA recommend that drugs should have label with pharmacogenetic information. Yeah, okay, slide. Slide, please. Yep. There are several drugs that already approved by FDA to have pharmacogenomic labeling. For example, like celecoxib, yeah, NSAID. We know that they metabolize by CYP2C9, so then the packet insert of the Celebrex, for example, need or should have information about the genetic profile, the genetic information. Okay, there are, I will not read all, but this is just example. Several drugs have certain biomarkers that need to be input in the information of packet insert. Slide. Yeah, and in the term of implementation for the clinical, so there is a CPIC, the Clinical Pharmacogenetic Implementation Consortium. They release several guidelines. So already there are several guidelines for the clinician to consider the genetic profile when they treat or will prescribe the medication. Yeah, okay, just move to the next slide. Yeah, you can search in the internet, it's very easy, to CPIC. If we have genetic tests, we can see that for the clopidogrel, for example, this is antiplatelet, people need to consider about the genetic of the CYP2C19 because it is very related. And for proton pump inhibitor, for example, need to see CYP2C19. And other like warfarin. Warfarin also anticoagulant that with a neurotherapeutic index, so we have to be careful to prescribe the warfarin. It related with the CYP2C9 and VCORC1. Okay, slide. Yeah, this is a clopidogrel. Clopidogrel is a prodrug that will be converted into the active drug twice with the CYP2C19. Yeah, CYP2C19 is the enzyme that converts clopidogrel prodrug into active drug. So, if individual have poor metabolizer of CYP2C19, so we can predict that they will form the less metabolite or active metabolite. Okay, next slide. Therefore, in the Plavix, for example, there is in the packet insert of Plavix, there is information, slide please. Here we see that there is information, pharmacogenomic information. Plavix at recommended dose form less of that metabolite and has a smaller effect on platelet function in patients who are CYP2C19 poor metabolizer. So if patients have poor metabolizer, so we have to consider alternative, because when we give the standard dose, so it will have the higher cardiovascular event or have less effect on antiplatelet. So we can adjust the dose, like increase the dose or change to other antiplatelet that not undergo the metabolism through the CYP2C19. Yeah, okay, let's slide. And next example, other example is warfarin. Warfarin is again anticoagulant with a neurotherapeutic index, so we have to be careful to prescribe that. Warfarin work on VCOR. VCOR is vitamin K epoxide reductase, which is also polymorphic. So there is gene polymorphism happen in this gene, this VCOR. Okay, next slide. Yep, we see here, this is two gene, both in pharmacodynamic phase and pharmacokinetic. The pharmacodynamic is in the target site, the VCOR. And there is three phenotypes with the homozygote GG, mildly resistant, AG, wild type, so the wild type or the normal one is AG, and AA is sensitive, okay? And in the other side, for the pharmacokinetic phase, there is also CYP2C9, where it can be polymorphic with star 2 and star 3 with decreased enzymatic activity. Please see on the table, we see that in the normal one with GG phenotype or AG phenotype for VCOR-C1 and CYP2C9 is still star 1, they can be given with dose of 5 to 7 milligram. But see from the corner, in the low corner, yeah, with AA, meaning sensitive to the drug, and have poor metabolizer with star 3, so they need only 0.5 to 2 milligram, meaning that only 10% of the standard dose for the normal one. You can imagine if we give the excessive dose, so then it can give the effect like bleeding. So if we can consider this genotype profile for considering the prescription is very helpful for the patient to get the optimal result of the medication. Okay, yes, I think I have reached the last part of my slide. So the pharmacogenomics provide a scientific foundation for advancing precision medicine and optimizing therapeutic outcome. Incorporating genetic insight into clinical practice is essential to enhance drug efficacy and minimize treatment-related risk. And sustained research and interdisciplinary collaboration are crucial to accelerate the implementation of precision medicine in Indonesia. And we open for this collaboration. Please just contact me if we want to have collaboration in this field. And ultimately, our collective efforts will contribute to a more evidence-based, safe, and patient-centered healthcare system. Thank you very much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you to our speaker, Professor Dr. Apoteker Zulis Ikawati, for sharing the great insight of the topics. So right now we are stepping into the Q&A session. Okay, all right. Maybe we can moving on to the next topic. Can we? Yeah, okay. Okay, thank you to our great.
So total number of students at my faculty is around 10,830, which makes this faculty as one of the largest faculty in Asia, Faculty of Applied Health Sciences, in which there are 45 disciplines, and we have more than 11,000 students, 70 plus degree programs, and 500 faculty members plus, and these are the 13 departments along with these numbers. Next. Then we have a total number of faculty 550, and the teacher-student ratio is 1:20 with all national and international visiting faculty. Next. So this is my university. Welcome to the University of Lahore, one of the beautiful university in Pakistan, private sector university. Next, ma'am. Again, next. This is the mosque and the building. This is pharmacy department and the medical college. Next. And these are the fun food and street areas. Next. This is the building of Allied Health Sciences. In fact, this is my building, and my office is on the first floor. Thank you with the AstroTurf, which is the first elevated AstroTurf in Pakistan. Next. Thank you. So as a Dean of Allied Health Sciences at the University of Lahore, I have dedicated my career to elevating the physical therapy profession and all other allied professions in Pakistan to global standards. My journey includes founding the University Institutes of Physical Therapy as well as clinics and pioneering the nation's first ever PhD program in my field, along with some other fields like University of Lahore, similarly, we are pioneer in, starting first ever program in so many disciplines of library professionals. I now also lead the state-of-the-art Center for Healthcare Simulation and Innovation, which enhances practical training for students, which is in fact my today's talk. In my national capacity as advisor to Pakistan Allied Health Professional Council and former chairman of Pakistan Physical Therapy Association, I remain committed to fostering excellence, innovation, and leadership for the next generation of healthcare professionals. Next. So I would like to have the attention of the whole audience that please have a look of this picture. How do we train for life's most critical moment? Look at this image. This is the moment of truth in healthcare, a moment where months of training, knowledge, and skill converge into a single critical action. Now ask yourself, how did this professional prepare for this exact moment? Was their first time performing this under pressure with a real patient's life on the line? For generations, the answer was often yes. But today we face a critical question. In an era of unprecedented technological advancement, can we truly justify an education model that relies on chance encounters and practicing on patients? I believe there is better, safer, more effective way. So this is my today's topic, that what is the role of clinical simulation in shaping tomorrow's healthcare professionals? Next slide. So the traditional paths, whenever we go through the traditional model, a foundation built on observation, there are so many strengths and limitations. The traditional model of see one, do one, teach one has served us for centuries. It immerses students in the real world and allows them to learn from seasoned experts. However, its limitations are becoming increasingly apparent. Learning becomes a lottery of experience. One student might see 3 cardiac arrests in a month, another might see none. This model can create anxiety, where the fear of making a mistake stifles the very learning we aim to foster. So in short, the strengths of the real world is real world context, learning from mentors, this is the strength. But there are so many limitations, including lack of standardization, patient safety risks, and limited exposure, and as well as student anxiety. Obviously, when we are encountering first time under so many high fidelity pressure, these things are likely to be happen. So I think this is the traditional model. Next. So there is a paradigm shift introducing simulation-based education that is a safe harbor for learning, a technique that recreates clinical experience in a controlled and safe environment. More than mannequins, task trainers, standardized patients, high-fidelity simulators, and virtual reality. This is where the paradigm shifts. Simulation-based education is not about replacing clinical experience. It's about augmenting and preparing for it. It is a safe harbor where students can navigate the complexities of clinical care without risk to patients, using a whole spectrum of technology from simple task trainers to advanced virtual reality. So this is the paradigm shift, that why there is a need to introduce simulation-based education, especially in every health setting, whether it is medical college, whether it is allied health sciences, basic sciences. Now, what we are learning at University of Lahore, since this is, we have just inaugurated the first ever simulation center for allied health sciences and the second center for medical sciences. So I think we are getting so much benefit of, after inaugurating this center. Next, ma'am. So the University of Lahore Hub of Simulation Innovation, almost 2 years ago, we inaugurated this Center for Healthcare Simulation and Innovation by University of Lahore under the leadership Faculty of Allied Health Sciences. This was Pakistan's first allied health simulation center. 7,720 square feet state-of-the-art facility designed to replicate an acute care environment. I've also requested Professor Maharida to play the video at the end of my presentation, just to give you people an idea about this simulation center. This is American Heart Association accredited, officially accredited by the American Heart Association for basic life support courses. So key facilities are the critical care unit. It includes 7-bedded simulation and a large multi-purpose educational hall. Our vision is to spearhead a transformative era in health professions, education across Pakistan. So we have brought this vision to life with the Center for Healthcare Simulation and Innovation. We are proud to be the first allied health simulation-based education institution in Pakistan. Having all other facilities, clinical offerings, fully equipped critical care unit to 7-bedded simulation ward to provide realistic, immersive experiences to our faculty and students. Next, please. You can have a look of this control unit room, and students are having hands-on skills on high fidelity simulator. This is an autonomy table, 3D autonomy table, and we have so many other mannequins and simulators for the training of the BLS and CPR and ACLS and a few other things. Next. So what we are offering comprehensive courses from core skills to critical emergency, like a foundation for foundational skills. We have virtual and physical anatomy tables. These are 3D anatomy tables, and then IV and IM sampling and IV intravenous arm training, auscultation and ear eye examination. Then advanced procedures, CVC management, lumbar puncture and suturing, 12-lead ECG interpretation, ultrasound based examination, high-stakes simulation skills like BLS, ACLS and ALSO, neonatal resuscitation, cord management, obstetric birthing, airway management and choking. So our curriculum is meticulously designed to serve the diverse needs of all our allied health as well as health departments, taking students on a journey from foundational skills to critical emergencies, like virtual anatomy tables I just mentioned, lumbar puncture and suturing and so many others. So these are the important simulators that we have even birth hands-on training on Noelle simulators and airway management. These are the basic techniques. Next, ma'am. So what are the game-changer pillars? We have basically 3 types of game-changer pillars: patient safety, deliberate practice, building confidence and competence. By having this, the first pillar of our approach is unwavering, that is patient safety. Our vision for the center is built on placing a paramount emphasis on patient safety from every scenario, from managing a core blue with our HAL simulator to performing a virtual lumbar puncture. It is designed to reduce the risk of errors in the real world. So mastering skills without patient risk, mistakes becoming learning opportunities, not patient incidents. The second pillar is deliberate practice. I mean standardized, reproducible and clear training for high-stakes, low-frequency events. We ensure consistent training that leads directly to one of our primary goals, improved skill performance, whether a student is practicing on an advanced circuit, like on a HAL ECG simulator, or a noisy breathing simulator, they are getting the standardized and practice needed for mastery. The third pillar, and the most important, building confidence and competence. That is our third pillar. It is a stated goal of the center to see increased confidence in every student who trains with us. Through realistic scenarios and structured debriefing, we instill the critical thinking and teamwork skills that turn a competent student into a confident, practice-ready professional. So forging resilient professionals, students transition to clinical practice feeling prepared, not panicked. So these were the three game changer pillars which we are experiencing on everyday activity while we are getting the progress in the simulation industry of Pakistan. Next. So these are the few stats that will show you that since year 2024, what we are achieving at our simulation center, that total number of students which were got encountered at simulation center were 2,700 in 2024. Total sessions delivered 511, 511, and center utilization rate as per working hours was 86.44%. You can see the virtual and anatomy sessions were 361, skill-based activities, simulation-based sessions like VLS activities and so many other activities were around 150, and total number of trained students were around 2,700. Next. So, by the way, in 2025, you can see the progress just since I've just getting the data from January to August. So progress so far at Center for Healthcare and Simulation Innovation at University of Lahore, total number of students encountered 4,000, while these were 2,700 in 2024. But now these are 4,000 in just 8 to 9 months. Total sessions delivered 700 in comparing to 500 sessions, and center utilization rate as per working hours is has been increased from 86 to 88%. So total virtual and anatomy sessions were 500, 200 skill-based activities, simulation-based sessions, and total number of students 4,000. Next. So closing strong, projections for the final 4 months in the year 2025, what we are going to expect that end of year goals September to December. Additional encounters, there were 200 plus additional student encounters, and year-end total achieved a landmark total of over 1,500 student encounters. So by this way, we are expecting to end the total number of trained students would be 5,500 at our center, including all disciplines of applied health sciences as well as medical and dental college. Similarly, there were 600 virtual anatomy sessions which took place at our center. Then we also had skill-based activity, simulation-based sessions were around 300. So you can see the progressive chart of interest and activity and productivity of this center. Next. So, by the way, I would like to share this also, that we also have a very strong memorandum of understanding between University of Pakistan as well as University of Muhammadiyah Madrasa almost 2.5 years ago. This was MOU signed between two vice chancellors of two respective universities. So my call is to this brings me to a call to action that our mission is to serve as a regional hub for healthcare excellence. I invite you to collaborate with us. Let us establish partnerships, share knowledge, and work together to fulfill our vision of expansion beyond borders, elevating healthcare standards for the entire region. Let us work together to establish partnerships. Let us serve as a regional hub for continuous professional development. Let us fulfill our vision of expansion beyond borders. So this was my call for collaboration to make our MOU more into practicality by bringing both universities, by bringing both faculties and experts, people from both universities to join hands together. We can also invite new people to visit our simulation center. Similarly, we can also visit your university to, if you don't have already simulation center, but then we can provide you consultation. But if you already have a simulation center, then we can have some joint courses, joint, expertise, and we can go for collective wisdom. Next. So this was my last slide. So in conclusion, simulation-based education is the proven game changer for allied health sciences as well as health sciences. Our own data shows a story of explosive growth and deepening impact, especially in the lives of students from different backgrounds. It is the bridge from the textbook to the bedside to growth and textbook to the bedside. By embracing it, we can build the safest, most competent, and most compassionate generation of healthcare professionals the world has ever seen. Thank you. I will now be happy to answer any question, but before that, I would like to ask admin if they can play the video of 1.5 minutes or around 2 minutes of our simulation center. Then I will be happy to answer any question. Yes, ma'am. Over to you.
Okay, so from the audience, do you have any questions to our speakers? Yes, please.
Oh, jadi sini saya coba tanya. Oh, yeah. Thank you for the opportunity. I interested about simulation-based training, Professor. In what ways can simulation-based training improve patient safety and reduce medical errors?
Okay. Can you repeat the question?
In what ways? In what ways can simulation-based training improve patient safety and reduce medical errors? Can
Yes, I got your question.
Yeah. So the question is, in what ways can the simulation-based training improve the patient safety and mental errors? Yeah. Medical errors. Okay, medical errors. Yeah.
Thank you very much for the question, Professor. I got it that in what ways that the simulation-based education improves the patient safety and medical errors. Am I right?
Yes.
So simulation-based education is a complete science, which is the need of time. And whenever we talk about the components of any clinical simulation, program, it includes the role of briefing and debriefing. That is again a very important aspect. So what we do, we go for some real scenarios in a controlled and safe environment in which we create the low fidelity and high fidelity scenarios. Like if a patient comes with hypovolemic shock or if a patient comes with any kind of emergency, so we always train all the students and always all the members to act immediately for such kind of activity. And there are so many simulated actors which are also available in such kind of environment. So I think that the psychological safety and patient safety is the important thing, that whenever you will be the trained person, like as I've already mentioned, that there are so many limitations that due to lack of exposure to the patient and due to lack of training, so there is chance to get the stake of the patient life. So if the student or the medical doctor is fully trained in a controlled environment, there is a less chance that he will do any harm to the patient. So the patient will be automatically will be the safe one by having the safe hands already trained in different environment. And definitely, as far as the madam said, that the medical errors, listen, that when we train our students in a controlled environment, like if a student comes to us and he's fully eligible to do that hands-on training at least 5, 10 or 15 times, he will be more confident. He will be doing less errors when he will be going into the real scenario of high fidelity simulation center. Thank you.
Okay. Thank you, Professor, for the answers. So from the
Can you play my video of 1.5 minutes, please?
video.
Video I have already seen.
Okay. Okay.
Simulation center.
Yes.
Thank you.
Please.
Thank you very much, Dr. Fatma and all the audience for having my speech, and thank you very much.
Okay, moving on to the next session for Q&A session for our first topic, the previous topic. So any question from the audience for our first topic? Professor Zulis? Yes, please. Okay.
Assalamualaikum warahmatullahi wabarakatuh. Thanks for the opportunity. My name is Wira Istika from Department Pharmacy.
To Professor Zulis, would you please invite you to in front of the podium? Yeah, okay, thank you.
Before I give some question, allow me to read some pantun for Prof. Sulis. May I? Jalan-jalan ke swalayan, beli pukis dan juga agar.
Cakep.
Ahlan wa sahlan Prof. Sulis, selamat datang di Makassar.
Give a round of applause to our lecturer.
The question is, how likely is precision medicine using genetic profiling to be successful in our country, in Indonesia? To make this a realistic approach, what are the key steps we need to take immediately? Thank you.
Ya, boleh.
Can you repeat the question? The last question. Yeah.
How likely is
What
precision?
are the yes?
How likely is precision medicine using genetic profiling to be successful in our country application? Okay.
Yeah, I think I got the questions. How about the implementation in our country, in Indonesia, I think now the Ministry of Health already consider the personalized medicine is one emphasized in the healthcare. So what we need to do is to provide more proof, more evidence that the importance of using the genetic profile to improve the outcome of therapy. So after we can prove that, so we can propose to the government, to support. I learned from the Thailand. In Thailand, the government supports a certain genetic testing. Not all, of course, because maybe it is costly, but only for for example, for the carbamazepine or allopurinol, because they can cause the Stephen Johnson syndrome. So for the people in Thailand that will get the allopurinol or carbamazepine or phenytoin, they have genetic testing for HLA star B certain gene, and it is supported by the government. So I think if we can provide more research and more evidence that it is important to use the genetic profile to predict the result of therapy, so then we can propose, I think we have to increase more research in this field, I think. Thank you. Thank you.
Yeah, thank you.
Okay, thank you, Professor. So moving on. Oh, we still have one more question, Professor. Please. Oh.
Kebetulan dekat.
So who would like to ask first?
Thank you for the opportunity. I am interested about a pharmacokinetic gene polymorphism. I have two questions, Professor. Can pharmacokinetic gene polymorphism predict adverse drug reaction? And the second question, which drugs are most affected by this polymorphism, leading to treatment failure or toxicity? Thank you.
Yeah, okay, thank you for the question. Yeah, I mentioned about the pharmacokinetic and pharmacodynamics. Pharmacokinetics more focus on the level of drugs, because the pharmacokinetics, we have 8 absorption, distribution, metabolism, and excretion. So it will influence the level of drugs. So for the pharmacokinetic phase for pharmacogenomic will give us to adjust the dose. So we'll give the information to adjust the dose, like poor metabolizer, for rapid metabolizer. So this is the phenotype of pharmacokinetic. While in pharmacodynamics, we see the receptor or we see the action. So like, for example, like if the polymorphism happen in a certain receptor, so we can give the alternative, because maybe the drug cannot bind the receptor, or maybe the effect is less than the normal. So we can give alternative. So I think both, we can predict the adverse, or maybe we can also predict not have a subtherapeutic dose. I think this is the benefit of the pharmacogenomic, both in pharmacodynamic and also in pharmacokinetics.
Doctor? Okay, you have satisfied with the answer, yeah? Okay. So before we moving on to the third speaker, I would like to conclude for the first and the second topic. So from the first speaker, so it is about the drugs, yeah, the pharmacology. So usually people do not respond to medicine or drugs in the same way. Even the efficacy can be also vary, and that can happen because there are many factors that influence the medicines. And also we must consider on the foundation of the pharmacogenomics, which is the pharmacokinetics and also the pharmacodynamics itself. Yeah. And also for the second topic, it's about about the rule of the clinical stimulation innovation, and yeah, it can also enhance the patient safety, yeah, and also the medical error. So without further ado, for the next session, we'll be given the appreciation to our speakers. For the first speaker, we would like to present the certificate of appreciation, which will be delivered by our dean, Professor Suryani Asad. Would you please, committee, prepare the certificate of appreciation for our first speaker? The committee and the photograph, can you please prepare? Professor Zulis as our first speaker. Thank you for the great insight of the topic. Would you please give us a round of applause? Oke, thank you, Professor. Sekali lagi tepuk tangannya yang meriah. A great round of applause to our outstanding speaker. Very well. To the next speaker, also we would like to give the appreciation certificate of appreciation to our second speaker, Professor Asfaq from University of Lahore. We would like to also give the appreciation certificate of appreciation via online. Can you please, the committee, present the appreciation to Professor Asfaq? Would you please give a round of applause for our second speaker? Thank you, Professor Asfaq, for your great insight of the topic. Yeah, we do hope we will meet offline in Indonesia. Okay, thank you, Professor. Yeah. All right, moving on into the third topic. And before that, I would like to invite our third speaker. I would like to invite our third speaker, Professor Dr. Suryani Asad, Magister of Science and Clinical Nutrition Consultant, to front of the podium. Would you please, Professor? So before that, I would like to read her curriculum vitae. So Professor Dr. Suryani Asad, Magister of Science and Clinical Nutrition Specialist Consultant, was born in Parepare. And for the educational degree, you can see on the screen, she has achieved the medical degree in Universitas Hasanuddin, and also the Magister program of nutrition in Universitas Indonesia, and also the doctoral program in medicine in Universitas Hasanuddin. Can you moving on to the next slide, please? And also we can see here, Professor has also achieved academical degree in the British Academy of Continuing Medical Education in Amsterdam, Netherlands, and also in 2019 in Scope School, Kuwait. And for the work experiences, right now as a dean in the Faculty of Medicine and Universitas Muhammadiyah Makassar, and we can also see there are many experiences in organization, and also you can move on to the next slide, please, and also many experiences in research, yeah, and also many activities that are very related into the clinical nutrition and also medicine. So without further ado, to Professor Suryani, time is yours.
Thank you. We have already. Assalamualaikum. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, this is the last session. Last third because there is one more presentation from outside. The topic is related to the implication of multiomics in gestational diabetes. We know that nowadays there are the prevalence of the gestational diabetes, and we know that formerly there is the physiological changes of the metabolic process during pregnancy, include carbohydrate metabolic. And then by improving the significance of detection of gestational diabetes, this is increasing advancement of the knowledge that not only for the disease as such, but there is another consequences related to nutrition, nutrigenomic, and microbiome. Slide. The agenda, we can discuss 3 steps. First, introduction, and then come to the basic concept of gestational diabetes and the summary. Slide. For the introduction, we can discuss 4 aspects related to gestational diabetes, and then the multiomics, nutrigenomic, and microbiome. When Prof. Sulis explained of the pharmacogenomic and pharmacokinetic, I remember that in nutrition there is also the same problem and the same aspect of the genetic aspect of nutrition. Slide. Gestational diabetic is a form of diabetes that occurs during pregnancy. Gestational diabetes, this is defined as carbohydrate intolerance, first diagnosed during pregnancy, and this is a common pregnancy complication. The incidence and prevalence nowadays is increasing, maybe because of the variability of the nutrigenomic and nutrigenetic is related. The rates of gestational diabetic are increasing in the obstetric population, driven by growing rates of overweight and obesity along with older maternal age. Our experience in the clinic, the one who get pregnant with overweight or obese is increase the occurrence of gestational diabetes along with the increase of the age. Yeah. Formerly, we find that the age of the pregnant woman more than 35 years is very related to gestational pregnancy. And the rate of the prevalence has been increasing, especially in Asian country. The prevalence of gestational diabetes exceed around 20%. In the hospital and also in some clinic in Makassar, the rate of the prevalence of GTM around 15 to 18%. And then between 6 to 9% of pregnant women develop gestational diabetes. This is according to the CDC Atlanta. So in the worldwide, yeah, the prevalence 9%, while in Asian countries 20%, in eastern part of Indonesia 15 to 18%. And then when we see the weeks of pregnant, 24 to 32 weeks pregnant and disappear after delivery. Yeah. So we know that there are two, yeah, the diagnosis, early stage or late, yeah, early diabetes in pregnancy or late. And we see that almost the rate of 24 to 32 weeks pregnant is the most frequent, the incidence and the occurrence of gestational diabetes. And then this symptom will disappear after delivery. Yeah. And the other around 2%, yeah, is possible develop gestational diabetes. Yeah. Meaning that before delivery, yeah, the gestational diabetes will appear after we giving birth. Yeah. And then 2% can develop to gestational diabetes a long life of the woman. Slide. Related to genomics, genomics is a field which involves identification of genes and genetic variants associated with a disease or in a response to certain drug and medication. Yeah. Not only for drug and medication, but also nutrient as such. In this approach, we call genome-wide association study are used to identify genetic variants in entire genome which are associated with the disease. While epigenomics refer to identifying modification of DNA or DNA-associated protein, include DNA acetylation or deacetylation and methylation. Cell function can be modified by modification in DNA, in histone, apart from genetic changes. These changes can be based on the environment and are passed on to progeny. Slide. What causes gestational diabetes? We know that the metabolism of insulin's job is to keep our blood sugar levels on target. But during pregnancy, the placenta makes hormone that prevent insulin from as well as it should high blood sugar level can be dangerous. Yeah, we know that actually in the first time of our pregnant, there is a physiological changes, yeah, include carbohydrate metabolism. But if we don't care about that problem, it will be, yeah, a danger, especially for the insulins to keep our blood sugar level on target. There are possible risks and complications for pregnant women and the baby if sugar isn't controlled. Yeah? If we cannot control the blood sugar. Insulin is a hormone produced in the pancreas that regulate the body's metabolism of fat and carbohydrate. It also helps the body turn sugar into energy. In this case, gestational diabetes occurs when hormone from the placenta block the effect of insulin, preventing the body from regulating the increased blood sugar of pregnancy effectively. Slide. Now, who is the most at risk for gestational diabetes? In our experience and as a clinical nutrition specialist in the hospital, there are 5 aspects, yeah, that we consider as a risk factor for gestational diabetes. One is overweight, yeah. Having a BMI of 30 or more going into pregnancy is one of the most common risk factor for gestational diabetes. The second is age. The older the woman, yeah, doctors have noted that women over the age of 35 to 30 have a high risk for developing GDM, with that risk increasing as get older. Yeah, mostly more than 35. Yeah, if we remember that 20 years ago, 30 years ago, yeah, the rate or the pregnant woman mostly 23, 21, but nowadays, yeah, it's becoming increase of the age around 35, even 40. Yeah, we have 2 patients with age 40 year become pregnant. It's the first pregnancy. And then the third is family history. If diabetes runs in the family, especially in any of first degree relative, may be more at risk of GDM. The 4th factor is personal history of GDM. Gestational diabetes during a previous pregnancy, the research found that, yeah, more likely to have it again in subsequent pregnancy. And the 5th one is pre-diabetes diagnosis. Yeah? That's why before pregnancy, it is recommended to test our blood sugar. Slide. The symptoms of gestational diabetes. Most women with gestational diabetes have no symptoms. Yeah? Though a few may experience unusual thirst, frequent urination in large amount, fatigue, and sugar in the urine. So, if this is the symptoms come up, yeah, please to check our blood sugar. Slide. Now, let's discuss about multiomics, integrative omics, panomics, or panomics. This is a biological analysis approach in which the data set are multiple omics, such as the genome, proteome, transcriptome, epigenome, metabolome, and microbiome. One of the participants asked about how about the pharmacodynamic and genome aspect implementing in Indonesia. Yeah. Pak Wira, yeah, if I don't mistaken, Pak Wira asked about that. We know that today there is an increasing diagnostic advancement about nutrigenomic and metabolomic. This is the use of multiple omics technology to study life in a concerned way. By combining this, scientists can analyze complex biological big data. And also in Department of Health, Kementerian Kesehatan is already have the unit of increasing and data of genome project. Slide. How about nutrigenomic? Nutritional genomic, as we can say of nutrigenomic, is a science studying the relationship between human genome and human nutrition and health. Nutritional genomic is the relation between food and inherited variants in genes predict how your body will likely respond to certain nutrients related to metabolism, energy expenditure, and energy balance. They impact weight management and body. This is the scientific study, confirm that the interaction of nutrition and genes, especially with regard to the science, the prevention and treatment of disease, the one of that, this is the diabetes in pregnancy. Slide. Now, a microbiome is the community of microorganisms that can usually be found living together in any given habitat. Microbiome was defined more precisely in 1988 by Whips et al. As a characteristic microbial community occupying a reasonably well-defined habitat which has distinct physiochemical properties. And human microbiome, the full array of microorganisms, that microbiota that live and in human, and more specifically the collection of microbial genome that contribute to the broader genetic portrait, a metagenome of human. And this is also increasing in the study about nutrition, microbiome, and health and disease. Slide. Now, we come to the basic concept about pregnancy diabetic. The basic concept of pregnancy atau diabetic pregnancy is epigenetic modifications such as DNA methylation provide a possible link between intrauterine hyperglycemia, exposure early in development, and metabolic status later in life. The status of DNA methylation is very sensitive to cell metabolism and nutritional status. As we know that in some metabolic system, for example, one carbon metabolism composed of the folate and methionine cycle generate universal methyl donor as adenosyl methionine, which is a substrate for DNA methyltransferase. And then 3-carboxylic acid, TCA, for energy metabolism, generate metabolite that link energy pathway with epigenetic modification. One of the substrate is alpha ketoglutarate, is a substrate of T80 enzyme, flavin adenine denucleotide is essential factor that lysine demethylase, LSD1 and LSD2, and also succinate acid and fumaric acid can inhibit the function of DNA methylase. This is the improvement of the metabolism already done via many study about nutrition related to genetic aspect of gestational diabetic. Slide. Now, the basic concept of that progress in line with the gut metabolic brain axis. This is the imbalance intestinal microbiota is associated with gestational diabetes mellitus, and also imbalance intestinal microbiota correlate with the metabolic profile. So gestational diabetes trigger alteration in the maternal microbiome. That's why nowadays there are many research related to microbiota profile of the pregnant woman. And alongside metabolic shift, microbial product may impact clinical factor and influence pregnancy outcomes. And imbalance in intestinal microbiota that may underline pathological condition in both mother and infant. So in the institution academic as well as in the hospital, there is a correlation between of intestinal microbiota and also related to metabolic profile of the pregnant woman. Slide. The summary of this, can we say that gestational diabetes mellitus is associated with considerable imbalances in intestinal microbiota that may underline pathological condition in both mother and infants. With the gut metabolic brain axis is the underlying process. Understanding personalized glycemic response of pregnant women to different dietary challenges can help establish precision nutrition recommendation for pregnant women with GDM, which can further improve the health of women and their offspring. That's why in the clinic, in nutrition clinic, facing the pregnant mother, especially who prone to gestational diabetic, we have to give dietic program or diet program based on the personalized, we call it personalized nutrition. Slide. For the direction in the future, epigenetic modification such as DNA methylation provide a possible link between intrauterine hyperglycemia. And there is a need of technology of continuous glucose monitoring makes it convenient to monitor glucose fluctuation, postprandial glycemic response, hyperglycemia, and hypoglycemic status and glycemic variability. The status of DNA methylation is very sensitive to cell metabolism and nutritional status. That's why it needs more research about this aspect to find more about the relationship about nutrigenomic, nutrigenetic related to gestational diabetic. Thank you.
Okay, thank you to our third speaker, Professor Dr. Suryani Asad, Magister of Science and Clinical Nutrition Consultant, for sharing the great insight of the topic. Would you please once again give a round of applause to our speaker? Okay, right now we are stepping into the fourth topic, and before that I would like to invite our fourth speaker, Professor Timothy J. Q. MD, PhD from Taipei Medical University, Taiwan, which will be joining us via online in Zoom meeting. And to the committee, would you present the curriculum vitae of our fourth speaker? Can you please zoom in? So our speaker, Professor Timothy J. Q. MD, PhD, was a professor in Department of Obstetric and Gynecology, and also a joint appointment professor in International PhD program in Cell Therapy and Regenerative Medicine, and visiting staff in Taipei Medical University, and also as a member in TMU Research Center of Cell Therapy and Regeneration Medicine. And for the education degree, Professor achieved educational degree in Department of Molecular Microbiology, Biology and Immunology in Johns Hopkins Bloomberg School of Public Health, as well as Faculty of Medicine for the medical doctor degree in the Faculty of Medicine in National Yang Ming University. And we can also see on the screen, there are many experiences of our speaker, experiences in the research, and also many activities that has been shown on the screen. So without further ado, we would like to invite our speaker, and the time and screen is yours.
It's my honor to have a talk for. Hi everyone. It's my honor to have a talk for your country and your university. Today, my talk topic is Health and Medicine 6.0 in gynecology cancers. I come from Taiwan, Taipei Medical University and Hospital. Sorry about it. I have some statements related to my intervention, the GM-CSF nucleotide sequence. You know, the traditional anti-cancer treatment have a iron triangle: surgery, radiation therapy, and chemotherapy. Right now, we have a target therapy, immunotherapy, hypothermia, and the cell therapy. Today, I will apply this novel therapy in our patients. This is a review article from Gynecology Oncology. You know, the immunotherapy have a immune checkpoint inhibitor antibody, and we can use a cancer vaccine, which is under development, and the cell therapy. The cell therapy majority for ovarian cancer and cervical cancer. There's 3 cancer included in the gynecological cancer. First one is uterine cancer, so-called endometrial cancer. The other one is ovarian cancer. The third one is cervical cancer. Let's go through it. Uterine cancer is related to the genetic factor such as Lynch syndrome, or some patient taking the tamoxifen for breast cancer maintenance therapy. There are some risk factors just like obesity, diabetes, and HRT. The incidence rate for uterine cancer is increasing worldwide. I am very lucky to join the international global trial. This is a Keynote 775 randomized open label phase 3 study. Use target therapy levatinib plus immunotherapy pembrolizumab compared to traditional chemotherapy such as doxorubicin or paclitaxel for advanced metastatic or recurrent uterine cancer. The data published in New England Journal of Medicine 2022, and they also got the approval in the 2021 for the use. This is so many researchers joined the clinical trial. The trial showed the MMR proficient subgroup, like a serous or clear cell, that provide survival, progression-free survival benefit. Also, overall survival benefit. The study combined with levatinib, this inhibit some growth factor, and the checkpoint inhibitor pembrolizumab to enhance the immunotherapy, increase the CD8 cell, decrease the Treg and the MDSC. So the phase 3 study changed the guideline for uterine cancer. So the levatinib pembrolizumab used for microsatellite stable or MMR proficient tumor, regardless of the histology. Then we go to the ovarian cancer. Ovarian cancer, we know that related to BRCA gene or HRD gene. Some risk factor is infertility or history of endometriosis. The overall 5-year survival for the ovarian cancer is about 49% for 5-year survival. But when you look at the advanced ovarian cancer, the survival is around 10% to 40% overall 5-year survival. And advanced stage ovarian cancer, 75% will relapse within 2 years. So advanced ovarian cancer is a challenge for clinical care. And there are so many associations that recommend the ovarian cancer patient should have a genetic test for all women with ovarian cancer. This is the first-line treatment for ovarian cancer. Before the 2003, the chemotherapy is a majority tool. Then 2011, they have anti-VEGF bevacizumab provide maintenance therapy. Recently, we have a PARP inhibitor. But ovarian cancer is not easy to have a complete response after first-line treatment. So if you want to go to the maintenance therapy, you need to make the patient in the first-line treatment got a complete response. When you look at the NCCN guideline, the stage 4 or advanced ovarian cancer, they provide platinum-based chemotherapy. If not work well, they suggest provide the best supportive care or so-called palliative care. The strategy to 2025 this year still not have so much progress. Let me show you a case. This is my patient who who have ovarian cancer stage 4 with malignant pleural effusion in 2021 July. This is a chest X-ray, and the right hand side is a CT scan. And in Taiwan, we have so-called cell therapy development. Compared to Japan, Korea, United States, or European, the regulation is so-called special regulation for cell therapy. The regulation starts from 2018. They allow the patient have a cell therapy for autologous cell, autologous immunotherapy, such as CIK, dendritic cell, TIL, or NK cell. The patient is a stage 4 solid tumor, so she is qualified for the cell therapy. This is the tumor marker CA125, and this is the patient's body weight related to general condition. So the patient have a right side pleural effusion, suffer from dyspnea, then do the surgery. The final pathology is ovarian cancer stage 4A. And after surgery, we do the intraperitoneal IP chemotherapy. Then to provide her the first night chemotherapy with the paclitaxel and the carboplatin. The patient suffer from the treatment. You can see the body weight is go down, and not only this, he suffered from the nausea, vomiting. So she asked, do we have any other option? So we provide, you have option to do the cell therapy. So after second chemotherapy, we keep the low dose chemotherapy. The traditional dose for paclitaxel is 175 milligram per square meter. And the carboplatin regular is 5 to 6 AUC. So with a low dose chemotherapy plus cell therapy, you can see the patient, the tumor marker keep going down, and the body weight also increase, even though during the therapy. The hemoglobin and the platelet maintain in the normal range. So the patient, after 5 cycles of combined chemokine-induced killer cell immunotherapy with traditional chemotherapy but with low dose, and the CT scan show the complete response, and the physical strength and appetite increase. Also, she have a sleep quality improvement. This is a follow-up CT scan. So the patient is very happy. So her daughter make a video. You can scan the QR code to see her sharing. So after the first line of management, the stage 4 cancer go to the complete response. We can use bevacizumab or PARP inhibitor to do the maintenance therapy. Then we go to the cervical cancer. This is my basic research related cancer. We know cervical cancer is related to HPV infection. And high risk group is smoking, unprotected sex, and multiple childbirth, long-term oral pill use, and have maybe smoking related to the reduced immunity. The cervical cancer, the incidence is going down because we have pap smear screening. But once they recurrence, they do not have effective salvage treatment for the recurrence cancer patient. The HPV virus was discovered by Germany scientist Dr. Ruhausen. This is the structure of the virus. They published in the 1981 Journal of Virology. They cloned the virus from the genital wart, then also from the cervical cancer patient. So right now, in the epidemiology analysis, we know the 99.7% of cervical cancer is due to the HPV infection. The correlation is very high compared to smoking and the lung cancer, alcohol and the oral cancer, hepatitis B and the liver cancer. So if we can block HPV infection, we can decrease the incidence of the cervical cancer. Not only the cervical cancer, but also go to the intranasal papillomatosis. And the lung have a respiratory papillomatosis. They have some basic research show the tonsil cancer also have some HPV infection. Some small group of the non-small cell lung cancer also have HPV 16 or 18 detected. And the lung cancer also related to P53 inactivation. About 10 years ago, we generate a codon optimized GM-CSF using the murine GM-CSF in the murine model. We try to generate a tumor cell cancer based vaccination. This is use a lentivirus infect the PC1 cell, and the codon optimized GM-CSF produce high quality of GM-CSF from the cell. Then the cell irradiate to become a cancer vaccine. They generate a good cytotoxic T lymphocyte reaction against the E6, E7 peptide. The idea comes from the HIV DNA vaccine. So we modify the gene sequence, then increase the protein expression. Then the novel codon optimized GM-CSF gene can be a DNA vaccine adjuvant against HIV-1 gag. And the finding, we file a patent and got the patent granted. So the cancer vaccine model have been applied to the novel research with Dr. Chen. She delivered the nitrous oxide with narrow carrier to promote the tumor vessel normalization, can potentiate increase the anti-cancer response. This is our collaborator, Becky Chen, Dr. Chen. The nanoparticle, nano-NO, nitrous oxide. If high dose nano-NO, the vessel is eradicated. If you use a low dose nano-NO, the vessel will normalization. Due to the normalization, using the chemotherapy such as doxorubicin, you can have a good penetration of the chemotherapy and increase the tumor killing. If the nano-NO combined with the gene therapy such as trail gene, they can have increased apoptotic cancer cell, also increase the tumor killing. The Becky Chen use a nano-NO combined with GM-CSF cancer vaccine. You can see they have a PD-L1 immunocheckpoint decrease and the increased tumor infiltrating T cell. Also M1 macrophage increase, then increase the tumor killing. The data are published in the Nature Nanotechnology. Due to the cancer vaccine immunotherapy, you can see the study group, they have increased CD8 cell infiltrate and the granzyme B expression in the tumor site. And the T cell activation increase, the mice have a longer survival rate. We have another study using target gene therapy, using the nanoparticle deliver to immunogene. This is a nanoparticle dendrimer, and the inside have a DNA or siRNA. We deliver the stem DNA in the dendrimer. Also use a PD-L1 siRNA to block PD-L1. The double gene immunogene therapy delivered to the mice, we can see they increase the tumor cell death. The data was published in the Science Advance. My graduate student, they use a cheaper approach. We know the tetanus toxoid. If we can vaccinate with a tetanus toxoid combined with our GM-CSF tumor-based vaccine, they can provide a good protection in the mice model. And the idea also applied to the glioblastoma patients. This is combination with tetanus toxoid. If you combine with the tetanus toxoid with TC1 cancer cell vaccine, you can see the mice, the tumor is smaller compared to the control group PBS. The tumor is larger. So the survival curve is this group is better. This is a review article about immunotherapy for cervical cancer. We know the anti-PD-1 already got the approval, and cell therapy is under clinical trial, and the ADC is have some evidence and got some approval. The DNA vaccine is under clinical trial. If you are interested, you can go to the recently new review article 2025. This is a recent advance in the immunotherapy for cervical cancer. The DNA vaccine combined with pembrolizumab. This is generated in South Korea. South Korea, they use intramuscular injection, 2 milligrams of the DNA vaccine. The data published recently in the e-clinical science, e-clinical medicine. The DNA vaccine plus pembrolizumab in HPV positive recurrent cervical cancer. This is a phase 2 trial. I use immunotherapy applied to my patient. This is stage 3C cervical cancer. The 2 cases got a PA lymph node recurrence. So you irradiate the PA lymph node. Then we use a low dose nivolumab as a maintenance for 1 year. If you are interested, you can go to the QR code. The data already published. Low dose immunotherapy is cheaper and affordable, and the case have no evidence of disease for at least 2 or 3 years. And I want to show you a special case. This is a 34 years old lady. She suffered from cervical cancer stage 2A, 2008. She got a recurrence 2 years later. The right pelvic have a 8 centimeter recurrence tumor. Then at that time we do the chemo radiation. The chemo radiation, but we find the tumor response is not good. So she joined a clinical trial. It's a great therapy, totally free. This is a EIE, so-called effective immune cell. Effective immune cell combined with IL-2 intravenous injection for the growth factor for the T cell. So far, complete response and the quality of life is improved. 15 years, no evidence of disease. This is a recurrence pelvic tumor, 8 centimeter. After the chemoradiation and immunotherapy, they totally disappeared. And the lady was survived, and she adopted a girl to be a mom. We know the cancer therapy, especially for the cell therapy, is good for hematology cancer. This is CAR-T, CD19, Emily, very famous patient. So if you want to do the CAR-T for solid tumor, but there's still some barrier, we need to walk through it. Our student Ditto do the bioinformatic analysis for ovarian cancer, then discover about 9 genes is a potentially target for the CAR-T cell therapy. The CSCR4 is very promising because this year we just published a paper in the Journal of Control Release with Dr. Chen, Becky Chen. This CSCR4 antagonist loaded the nanoparticle. They can reprogram the tumor microenvironment and enhance the immunotherapy in the hepatoma cell model, hepatoma animal model. This is a nanoparticle carry the CSCR4 antagonist. This the compound. The compound can change the immunosuppressive tumor microenvironment into a immunostimulation microenvironment, so increase the tumor death. Not only the study, we also work with Dr. Jenny and Ditto. This is my master student. They use a codon optimized influenza H1 gene. They have worked out for many years, but Ditto made a paper published. We have a codon optimized CHA gene and combined with the CTLA4. This combination made the antibody increase, then protect the mice from the Vaccinia H1 virus challenge. In Taiwan, we have a company. There's a PuppyBase. The company have FDA approval for the phase 2 study. This is a DNA vaccine. Want to prevent the CIN2 or CIN3 patient become a cervical cancer. We'll use a gene gun. This is a machine to deliver the DNA vaccine. This is our Ditto's thesis defense. All the advisor was support Ditto's presentation, and she got graduate last year. And we also in the Haras food. Okay, this is our team, our hospital, just close to the 101 building in Taipei City. And welcome your visit. Thank you very much.
Thank you to Professor Timothy. Okay, for the great insight of the topic. So right now we are stepping into the Q&A session. And I would like to remind to the audience that the questions that are addressed to the third speaker will be answered in the podium. And the questions that are addressed to the fourth speaker can be submitted through the email and also we can, with the help of the committees. So for the time efficiency, any audience can ask a question to our speaker for the third speaker, because the fourth speaker can be submitted through the email or with the help of the committee. So for the third speaker, any question from the audience? Are there any questions for our third topic from the third speaker? Regarding with the diabetes in a woman with pregnancy, gestational diabetes. So, any question from the audience? So, is there any question? Yeah, okay. We have one.
Yeah, Assalamualaikum, Prof. Yeah, the question, your topic is about the nutrigenomic in pregnancy women. The question is how we can do the examination, the nutrigenomic examination in the pregnant woman, and how is the impact of by knowing the nutrigenomic status for the pregnant woman? Thank you, Prof.
Yeah, thank you. Nowadays, it is preferred to test nutrigenomic aspect of pregnancy. Yeah. We know that during the pregnancy, there is physiological changes of the metabolism. There are 5 aspects. One is BMR, basal metabolic rate, with in the first semester is reduced and then increase the second trimester until delivery. And beside BMR, also the functional of GI tract. Yeah, we find that there is a difference of the nutrigenomic aspect, and also for the microbiota profile of the pregnant woman with the high blood sugar differ with the normal blood sugar. So, and also we looking for is there the full metabolizer, well metabolizer, or poor metabolizer. Yeah, for example, carbohydrate metabolism. Yeah, jadi because maybe you can understand for Indonesia. Ya, jadi pada saat kita seorang ibu yang hamil, ya, itu ada perbedaan ya metabolisme karbohidrat ya bagi mereka yang sensitif untuk insulin dengan yang tidak. Ya, that's why as a clinical nutrition specialist, we have to give them carbohydrate different from the normal one. Jadi kita harus lihat metabolisme karbohidrat yang diberikan kepada pasien-pasien dengan mereka yang cenderung untuk mengalami gestational diabetes dengan yang tidak, karena ada kemungkinan ada yang disebut dengan poor metabolizer, jadi karbohidrat itu bisa di metabolisme, ada yang bagus, ada yang tidak. Kalau tidak bagus, itulah dia cenderung menjadi apalagi gestational diabetes, ya, sehingga memang kita perlu melakukan profiling ya pada pasien-pasien kita. Ya. Nah, kalau di Makassar itu sudah ada kan Prodia yang melakukan profiling untuk kondisi-kondisi seseorang. Ya. Udah.
To the audience? Yeah. You satisfied with the answer? Okay, thank you, Doctor. And before we move to the last session, I would like to conclude the last two topics in this evening. So the implication of multiomics in gestational diabetes is very important, especially in carbohydrate intolerance or metabolisms. According to CDC, it's about 6 to 9% women will develop gestational diabetes. So it is very important to assist the patient and to regularly check the blood sugar as well. And also related to genomics, we can also consider other risk factors such as the BMI, the age, especially above 35 years old, and then the family history, the personal history, and also if the patient has the pre-diagnosis of diabetes, it is very recommended to test the blood sugar before planning on pregnancies, yeah. And also the multiomics and also the nutrigenomics can also help to predict how our body respond to food and help the pregnancy woman, especially the pregnancy woman with gestational diabetes, and also the metabolical status later in life. And for the fourth or the last topic, discussing about the gynecology cancer, especially in the ovarian cancer, and there are several studies on the, especially for the cell therapy on management of ovarian cancer. And after 5 cycles of combined CIK cell immunotherapy, there is an improvement and also enhance the treatment against the cancer. So I think that's conclude our topic, the last 2 topics. And before that, we would like to present a certificate of appreciation to our speaker, Professor Dr. Suryani Asad, Magister of Science and Clinical Nutrition Consultant, which will be delivered by our 4th Vice Dean, Dr. Ihsan Jaya MH. Would you please come in front to the podium for the appreciation? Yeah, Prof. Would you please give a round of applause to our speakers? Okay, thank you, Doctor. Yeah, another? Okay, please. Okay, thank you, Doctor, and also thank you to our speaker, Professor Suryani Asad, for giving us such an insight topic. And yes, thank you, Doctor.
Selanjutnya, pemberian sertifikat kepada moderator,
Okay, thank you so
Dr.
much.
Fatima
Yeah.
Mapanyumpa.
So we are now at the end of the plenary lecture. Who wants to give me the appreciation? It is a great honor for me, honestly, yeah. Yeah, because this is a very sensitive time. Everyone is starving and also sleepy. Yeah, okay, thank you, Doctor. Okay. We are now at the end of the plenary lecture session. And I'll give back to the Master of Ceremony. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Baik, mungkin inilah rangkaian acara kita pada hari ini. Dan diharapkan kepada seluruh peserta untuk bisa menghadiri gala dinner untuk malam hari nanti pada jam 7 waktu Indonesia Tengah. Terima kasih.